I'm going to discuss the basics of carotid sonography, and in particular, the Doppler and grayscale evaluation of plaque. I'd like to acknowledge Leslie Scout from Yale University for additional information that she has provided. In this lecture, I'll talk first about the technique of carotid sonography, something about the grayscale assessment of plaque and the vessel wall, spectral Doppler analysis, color Doppler, and end with some pearls and pitfalls. First, the technique. In general, we use a high-frequency transducer in the 5 to 12 megahertz range with the patient supine and the head on a bolster with the chin up. I like to turn the chin away from the side at which I'm scanning to expose the carotid artery to maximum advantage. The examiner is usually to the side, but some people prefer to examine from the head of the bed. Here's an example of how most people do it. The transducer is placed on the neck with the patient sitting at the side of the patient. The success of the technique depends on several factors, but it is most important that the patient can cooperate in some way. If a patient has had perhaps an acute brain injury, they may become agitated or demented and be unable to cooperate. Further, if they were to fall asleep and to snore, then useful information is difficult to obtain. The grayscale of assessment hinges on several things. One is, what is the plaque characteristics? What's the symmetry of the plaque? What are some of the surface features of the plaque? And then finally, percent stenosis. To remind you that the wall of the carotid artery should be thin. In many Western countries, you will see what is known as intimomedial thickening, which can be up to 1.2 millimeters and still be normal. Exceeding that threshold is considered abnormal. This is an example of the intimomedial thickening that I'm describing. At times, instead of focal plaque, you'll see a concentric thickening of the vessel wall, and there are several things that can give this appearance: radiation, Takayasu's arteritis, temporal arteritis, and fibromuscular dysplasia. Frequently, this is seen in the common carotid artery. You can see in this image the wall thickening here that surrounds the carotid artery. In this case, the patient had Takayasu's arteritis, which involves the major vessels from the aorta. Here's an example of fibromuscular dysplasia. Again, this is the carotid artery, and you see the wall thickening. Here is the classic appearance on angiography, the beaded appearance of the internal carotid artery in this case. So plaque, focal plaque, can have different echogenicities. They can be homogeneous or heterogeneous. In general, heterogeneous plaque is associated with instability because that suggests the presence of intraplaque hemorrhage. Here is the carotid artery here. You can see this plaque protruding into the lumen of the vessel, and the low echogenicity center indicating intraplaque hemorrhage and plaque instability. In general, hard plaque is more stable than soft plaque, and by hard plaque I mean plaque that has a high level of calcification. So this would be an example of hard plaque, and you can see the shadowing associated with that calcification posterior to the plaque. One thing about hard plaque is that the shadowing will make segments of the vessel inaccessible to Doppler interrogation. If the sound waves are not reaching it to create a grayscale image, neither are they reaching it to create Doppler images. So no grayscale, no Doppler. People in the field, if you are trying to insonate that segment of the carotid, frequently find it helpful to insonate the vessel from a different angle, or a different perspective. The surface characteristics of the plaque has been identified as an independent stroke risk. The surface characteristics are, however, difficult to identify with certainty and to characterize in some cases. But as a rule, smooth plaque is more stable than irregular plaque, and irregular plaque is the kind of plaque that can give off emboli and result in embolic strokes. Ulceration is seen as a deep pit or break in the plaque, and this can be difficult to identify. Here is an example of a plaque ulceration. Here is the plaque. Here is the flow into the heart of the plaque, indicating an ulceration. Frequently, in the presence of ulceration or plaque irregularity, you will see eddy currents or abnormal or unusual patterns of blood flow. Here's a color Doppler image with 3 different sampling sites, 1, 2, and 3. And you can see that both the direction and the character of flow changes radically as we sample different portions of this vascular segment. The grayscale assessment is usually done both in transverse and longitudinal planes. It's important to identify certain landmarks, notably the carotid bulb and the carotid bifurcation, and to identify the individual components, the common carotid, internal carotid, and external carotid arteries. When we do see plaque, we often measure a % diameter and assess for area stenosis. To remind you a bit about how these things are typically reported, usually stenoses are reported in terms of a % diameter stenosis, which is not the same as cross-sectional area reduction, because a 50% diameter stenosis corresponds to about a 70% area reduction. And similarly, a 70% diameter reduction corresponds to critical stenosis or severely flow-limiting lesion. This type of stenosis is typically measured in the transverse plane, but beware of asymmetric or soft anechoic plaque, which can be missed. In general, power Doppler, if available, can define the margins of the plaque with greater precision than color Doppler. When you do measure the luminal diameter narrowing, typically there's 2 ways of doing it. Most programs do it using what's called the NASCET criteria. That's an acronym of N-A-S-C-E-T. And the NASCET criteria is based on a endarterectomy trial, the North American Stroke Treatment and Endarterectomy Trial. And it's measured by measuring the luminal diameter of the vessel at the stenosis and dividing that by the diameter of the normal downstream ICA. So by NASCET criteria, the luminal stenosis would be measured as a ratio of the diameter A over the diameter C. Some people have embraced the concept of measuring what's known as a residual lumen at the stenosis. In general, the diameter of the ICA is 5 to 6 millimeters, and if there is a residual luminal diameter of 2 millimeters or less, then the lesion is in the surgical range. That is the greater than 70% diameter reduction.